Thank you for the kind introduction. My passion for all things healthcare stems from my background in microbiology and embryology, as you can see with the younger me picture over there. My years of experience in these areas gave me a deep understanding of the inequities that existed then and now. My hope for our healthcare is one that embraces Ubuntu. Ubuntu is a Southern African philosophy, meaning I am because of you, and we are because of each other. It means our humanity is inextricably intertwined. I dream of a system where everyone is valued and receives bias-free quality care. Imagine an environment where clinicians leave their biases by the door. Imagine an environment where the manufacturer does not use race-based data. Systemic inequalities are deep-rooted. They're beyond the cases that you see in the newspapers. They are actually rooted in the systems. And that's what I plan on sharing with you today. Inequalities persist throughout outdated medical frameworks influenced by historic racism. Before you become defensive, I urge you to take your defensiveness and turn it into curiosity. To better understand the inequities, we must remind ourselves how policies are made, starting from Canada Healthcare Act, following and filtering it down to Health Canada medical regulations, and all the way down to how the policies are developed and how they are enforced. Race is often misused as a biological determinant, leading to misdiagnosis, poor treatment, and inequitable care. In our short time together, I will show you how regulations have inbuilt biases. For example, Black patients are often prescribed certain medications based on assumptions, potentially limiting effective treatments. Current protocol limits Black people to thiazide diuretics, as well as calcium channel blockers. ACE inhibitors and ARBs are first-line treatments, and they don't get the opportunity to get the second, third, and fourth line treatments. Imagine Black or Asian people having a misdiagnosis or underdiagnosis of conditions like COPD because spirometers use race-based factors that assume Black and Asian individuals have lower lung capacity. The alarming concern is that the correction is actually pre-programmed in the equipment. So most users of the spirometer do not realize that they're actually using race-based data when it asks you what race the person is. The calculation is already in there. Now let's go to the oximetry. Pulse oximeters overestimate oxygen levels in individuals who have darker skin because the light doesn't get absorbed as it should. This actually led to higher rates of undetected hypoxia in Black patients during COVID. The obvious fix is to buy the right instruments. But we know that clinicians are actually simply told to rely on observation. Keep an eye on the patient. But we also know that we have a shortage, as we have heard earlier. Another dubious example is the bias that we see within the labor and delivery section, where Black, Indigenous, and Latino women are more likely to undergo C-sections, often due to a biased clinical decision-making that is based on the calculations, again, that is within the system. And it's also because of less of access to supportive care and misrepresentation of pain levels. The calculation used is an algorithm that deducts the points specifically for Black and Latina people, and then it recommends that they get a C-section rather than a vaginal birth. Next, we'll talk about the algorithmic discrimination that exists within the alpha-fetoprotein pregnancy testing. For this, you're trying to detect chromosomal abnormalities as well as the neural tube defects. And the misdiagnosis that comes with this actually leads to misclassification of risk in Black, Asian, and Indigenous people. My hope for healthcare is that we have a healthcare that moves beyond race-based medicine and that we prevent the misdiagnosis and inadequate treatment and poorer health outcomes. Policy plays a big role in ensuring that medical devices are not pre-programmed with race-based assumptions. We need bias-free treatment, and we need to make sure that all patients receive equal care. My hope is that we can build trust with equity-denied groups by making sure that the clinical trials are done in a meaningful way and that we build back trust that was lost before. Radical empathy is key in transforming healthcare and in ensuring every patient is seen, heard, and valued. Will you join me in ensuring that our healthcare system is rooted in Ubuntu? Because we know change begins with you and you and you. Thank you.